So good afternoon, everybody. Welcome to the grand rounds for Yale Cancer Center and Smilow Cancer Hospital. Today, as you know, it's really a reflection from the director on the state of the things, essentially looking back at what we have accomplished, but also looking ahead for the next year. Next slide. Okay, I think everybody knows who I am at this point. I've been serving as your interim cancer center director since March 1st, and really has been a privilege and a pleasure to get to know this wonderful community in more detail over the past few months. Next slide. And I think the other point is, of course, we're in this state of anticipation, but mixed in with a little bit of, I would say also, what's coming. And I think everyone's seen and met with Eric, and if you haven't, I know you're in for a treat. He was in our network committee meeting this morning, and a wonderful human being, and I'm just couldn't be more excited that we've been able to recruit Eric, who, as you know, is a former Yale alum and will be joining us February 1st, but as he has learned, has been already a part and parcel of our community. As soon as you sign the job, you start to become involved, so we've been really excited to have Eric be a part of our community. Next slide. Okay. So as we talk about sort of our cancer center, and Renee, you'll put I guess the CMB code. I think it's helpful for maybe my perspective, and maybe for those of you who are new, and some of you maybe who've been here for a while, it's helpful to look at maybe how fast we have grown. And I think sometimes when you're in the midst of it, you forget how much we have done. So, just a little history lesson. 1974, we started the Yale Cancer Center as a comprehensive cancer center. It's 2010 when the Smilow Cancer Hospital was built. And then the network was launched only 2012, so it's really recent. And then if you see the Cancer Biology Institute open on West Campus in 2015, our phase 1 unit in 2016. And then in 2018, as Dr. Fuchs was here, as Charlie were here, we went through a renewal and had an outstanding score, along with what is fabulous is to see an increase in our research funding. And then as you look today in 2021, in between, we've gone through and are in the midst of a pandemic. But I think it's helpful to look from a perspective of where we are, and the red stars, for those of you who are aware, are our care centers. And those are scattered around the state of Connecticut. We are fortunate that we're the only academic institution in the state of Connecticut. And then what many people would love to see is a distributed delivery system, which is here. As you can see, it exists through Connecticut and also through Rhode Island as our site at Westerly. This is something that's unique, and it's built up very much in the last few years. I think it's growing pains in some of the stuff that is ongoing now that you feel, but as Eric comes on, as Dr. Weiner comes on, I hope all of you will think around how do we connect all of those pieces together. And if you go to the next slide, Renee, I think the way we think about it is we want to build an academic health system. If you put our signage, whether we call it YNHH or Yale or whatever, it is to, why do we do this? It is to deliver care to our patients. And we are an academic system, which means we're a teaching organization. It's part of our tripartite mission. And that means how do we educate the next generation, whether it's trainees or nursing or the next generation? How do we take research and improve our patient care? But it can't be done in silo, and especially as we look at the cancer center and the distributed nature, not only of the sites, but of the constituencies, how many folks are involved. There are roughly 300 members of the Yale Cancer Center. And then if you look at the number of people, if you look at our nursing, our staff, it's 2,000 people. So that's a lot of people, many departments, many sites. And that talks about, it's great to see it, but then the day-to-day can sometimes feel difficult, sometimes fabulous, but it all means that we have to work together. And this is just one quote from Helen Keller in talking about, it means that we have to learn to work with each other, think about what we do great, and where we have opportunities. And that, I think, is probably more telling today as we look in 18 months into a pandemic, that some things work wonderfully, but some things we know our health systems could do so much better. Next slide. So this is important also in terms of thinking about what we do and why we do it. This is our vision statement. I think sometimes these are put in on websites, but I want us to think about how we deliver care. As healthcare teams, we deliver care one patient at a time, not in the abstract. It's one patient at a time, and it's each and every interaction. So when we talk about the tripartite mission, research, education, clinical innovation, and then increasingly we add community, it becomes very real in the patient interactions, whether it happens at Westerly or in Torrington or in New Haven. And how do you conceptualize and deliver all of this transformational care? It's easy to say when I'm talking about it in a PowerPoint, but then it's the teams that put it together. And those teams include our nursing, our residents, our staff, our clinical trialists, our leadership, our administrators. And then I think you get the soup of what we are trying to do. We're trying to make magic each and every day and improve the lives of our patient. Next slide. Okay, so when we look at this idea of what does the clinical care, and of course we then use our Smilow standards, the goals we would say is we want to deliver care that's easily accessible. So that means when we want a patient appointment, it's available to us as how you would want your family treated. I think the standards we hold for ourselves is that care is good, and that can be defined as that it has good opinions of pathology, radiology, imaging. Those things matter, as it's been shown time and time again. Also means the care delivery for a patient standpoint is multidisciplinary, that the patient can see all of the parts the specialists they need in a more streamlined way rather than going in serial one after the other. That's not very patient-centric. And of course, we can use care pathways. We then need to focus about how do we improve care. But I think the other part, and I want all of you to sort of take the, as we think about this, clearly there's what we do today, but part of the mandate for academic health systems is how do we improve the care for tomorrow? And that means how do we take the research, the quality to improve care? And I think you've seen that in the town halls that push that all of the teams come together to talk about, learn about each other, whether it's how do our nursing teams interact and how do we deliver care, or how is all this basic science related to something very granular, like how do we deliver care to our patient who's sitting in front of us. So this is the hard part. It's why we are here, but it's also where we have to flex our muscles and work together. Next. Now, as we look back in the year, it's been probably very much, I think sometimes we need to take a pause and breath and say, how much have we done? And we've done a lot. The Fearless team you see on your left is our two leaders on our day-to-day clinical operations, Kim Slusser, our Chief Nursing Officer, and Kevin Billingsley, who is our CMO. And both of them have taken us on a lot, whether it was through the pandemic and all the changes that happened, and then how we regrouped and delivered care back again and how we continue to do it. Of course, I want to acknowledge that this year we went through Magnet, and that is really reflects the work of our nursing team and all the great work we do. I think as we look around all the teams and how this has been done, a lot of the stuff beyond reestablishing care, and I will say it's not all reestablished as where we expected. I think our bar has changed as we come back with all the changes of, last year we moved from North Pavilion to SRC and clinics moved and then some came back. There's still some disruptions, but in the midst of it, we've continued to train our nurses and our teams. We've continued to work on improving things, whether it's through this lean task project for improving scheduling for infusions, launching patient experience forums, improving residency training, resident-centered care training for our teams. And then at the end of it, I think we have to think about how do we improve the patient experience. As you see this, each team, and I'm not going to go through all of this, but each team has put in their goals for the next year. It is important for us to look back, acknowledge the hard work of each and every team, but also look ahead and say, what do we want to do for the next year? And as you can see, they are obviously focused on many things, certainly focusing on what is up front and centrals. How do we improve our recruitment and retention strategy? I think this is a nationwide phenomena. It is most acute for healthcare, as we're seeing that our teams that have worked through the pandemic, we're seeing changes. So we need to think about how do we retain our best people. But there are other things. How do we improve care? How do we look at quality and morbidity and mortality conference? How do we look at our patient experience with our Prestini and enhance that? And this theme you will see across is how do we, I think the Black Lives Matter engaged all of the communities, and we have been having a national conversation, and that will be seen in the cancer domain. So you can see that they're focusing on culture, engagement, and DEI. This is looking inward, but also outward. We're going to have to do both. And this is the part that this team is also looking. Next slide. So this just acknowledges, I think, all the arrows, all it says is all the stuff. You all felt it. It was hard work. I think we can now smile and say it was great. I will still remember when we reopened the North Pavilion floors and how much excitement there was and happiness with our teams. But this kind of the chaos of this arrows reflect all the hard work you all did. I want to thank you all. I want you to acknowledge each and every one of yourselves and pat yourself on the back. It was hard work. Perhaps we never felt like we had a pause, because as soon as we moved, the work continued coming and continues coming. We're busier than ever. But I do think it's important for us to say we did it. We have that core in us. And as we look ahead, we have that ability in us. Next slide. However, things are not pristine, and I want to be honest that things are still in flux. I've talked about the labor challenges. I think we are busy. If you don't see that, look at our ED. It's always busy. It always is about 60 to 80 patients waiting to be admitted. And that means that some of our places are not where we expect that. I'm not going to go through and reiterate all of the clinics that are probably still not where you all thought. And perhaps some of that will mean that we may change over time. That's not a good or a bad thing. It's how we look at it. I always say the glass is not half empty or half full. It's waiting for us to be filled with all the colors we want to see and the flavors we want to put. And that's what I want you to think about. Now, it does mean that spaces get tight. We have to acknowledge that it's sometimes hard. It means that programmatic growth sometimes doesn't seem obvious or sometimes can be difficult. But I can guarantee you there's ingenuity and creativity in all of you, whether it's the nursing teams, whether it's the trainees, or whether it's the physicians. Every one of us has that capacity and that skill set. Next slide. Okay, so some of the other stuff, besides talking about the pandemic, which I think we've spent a lot of time, is some of the good stuff that happened while we were just so busy catching our breath on doing routine care. So, often in crisis, sometimes the best minds and best solutions are born. And the hospitals program was launched over the past year by Dr. Karen Edelson, along with Dr. Jensen Morris, who if you haven't met, she runs our hospitals program. And although it's only been launched for a few short months, the early signal shows that having a dedicated team does improve things like length of stay and early discharge. So again, it's a positive signal. It's something we'll continue to learn from. And as Eric comes on, this will be something for us to discuss and see how this relates to how we deliver our care, but also think about how does it impact our trainee experience? Are we thinking about all those facets and training the next generation? But I think early on, really remarkable success of working across different programs and across our institution. Next slide. And other things are this Next Day initiative. I think if it's someone in your family, if you have a cancer diagnosis, we would all say we want to be seen as soon as we hear about it. And that's the right intent. We need to think about our patients, how we would want to be treated, and they want to be seen next day. So this is an initiative launched by Sarah Mogalian, who's our ambulatory officer, along with Lisa Shumsky. And the data shows that this has launched in several locations. I'm not going to name them all, a lot in Southern Connecticut, along with other areas. And what it has shown is that we are able to do this for things like breast cancer care. About 15% of people are being seen by the next day. And also we're seeing about 10% of people being seen in the next day. So there's a huge patient demand for this, and offering this is something that we need to start doing. But the dynamics of it become hard because it does mean it puts stressors on the frontline team to think about how do we work more intelligently around this rather than just making our days go longer. Next slide. And then patient experience, which is critical around how we think. As you know, Tara Sam presents a lot of this, and she's helped by her Director of Patient Experience, Michelle Kelby-Albert. And some of the experiences that they have really done is the patient experience forums. We've talked about those. And then we formed the PFAC, these patient and family advisory councils, where patients educate us on what are the missing things that we may never hear about or think about. And I think those are important dialogues because partly we live, and when we deliver this tripartite mission, I say we do it in a community. Some of that community is us as human beings, but we live in a community. I'm currently sitting in New Haven. Some of you are sitting in Torrington or Waterford or in Westerly or Greenwich. So what does that community think about us? And this is, I think, thinking how do we make these abstract notions very much local and important to our patients who live within that community. Next slide. Okay, so some more data in terms of thinking about new patient volumes. This is helpful. We had a lot of growth. You can see up till 2017. I think some things plateaued down, and as we look in 2020, 21, I think some things for us to look and pause and say, where are areas where we need to focus on? Again, this is just more thinking about, and as we think of our strategic framework, and I know many of us spend a lot of time thinking about it. Next slide. And then just in more data, what are the work RVUs associated with our work? That's one way of how we measure work. There are many other ways, but this is how we measure one of our domains of the work, and it just shows the data over the past few years. Next slide. And then, of course, even though I shared the new patient data, of course, as we all know, as you get busy people keep getting busier because your patients continue to follow us, and you can see that growth is exponential, because those patients stay with us. And I think this is an opportunity of working. How do we use telehealth in this population? How do we think as teams around our follow-up visits? Is that always done the same way, or are there smarter ways of doing this as we look ahead? Next slide. And then I want to make a point. This is a complicated slide this is monthly, starting in October on the x-axis, going all the way to October 2021. And what you can see is in blue is in-person visits. The light blue color, or whatever we call it, is video, and then that orangish color is telephone visits. We all know that telehealth took off as the pandemic happened. So you can see that although for cancer, patients still need their infusion and need to visit us. So we continue to do a lot of inpatient visit, whereas, my other hat is I'm the head of the Yale Medicine Practice Plan. If you look telehealth across our health system, it was up to 30–40%. But here it was about 20% back in last year. And the rest of the trend is not atypical. We see that as things opened up, patients wanted to see us more in person, and that's what we see here, that the telehealth is declining. I think phone, as you all know, was not reimbursed, there's some reimbursement, so we encourage video. But as we look ahead, I don't think you should abandon telehealth. I think there are opportunities similar to what I mentioned around the follow-up visits, and what I mentioned early on, as we look at our care centers and they're distributed, and if you're thinking of an academic health system, not everyone has that expertise. If you look at, in every domain, and how do we bring the specialist? Can we use telehealth as a tactical way rather than everyone going to visit that patient, to bring that specialist to remote sites? Again, the answer is not today, but those conversations are happening. But delivering that will require some nuances as we pilot them out and think about it. I know certainly in surgery, I've seen some nice areas in Waterbury with thoracic doing this, and I think there's opportunity for us to think and use it across as holistically. Next slide. Okay. Now, although we are very distributed, there are 4 divisions that are part of the Yale Cancer Center, and I think it's important to think about what they do because they're full-time in the Cancer Center. So Roy Herbst runs the Division of Medical Oncology, and although it's one of our largest division with about 80 people, clearly a lot of work, and I'm not going to be able to acknowledge it. Some of the key highlights is they have multiple SPOREs. They're also trying to get faculty development and recruitment as we continue to be busy. Lots of drug approvals you can see in head and neck, lung, and bladder cancer. And I have to say, this team has worked really well on faculty, staff, and wellness during the pandemic. For next year, they continue to think about faculty recruitment and development goals. Also, how do we bring that academic piece in the system as fellows come out and they want a much more different practice than perhaps in the past. And they're looking at putting in a fourth SPORE application in breast cancer. Next slide. Looking at Division of Hematology led by the Stephanie Helene, who, as you know, took over the division over almost about 2 years ago, and obviously focused on the tripartite mission, as I mentioned, but also, as I know Stephanie also thinking about how do we disseminate innovation throughout the world, because the research here is phenomenal. Now, if you move to the next slide, I think what needs to happen is, and what Dr. Helene is very much focused on, is how do we bring that depth into all the programs, because lymphoma is very different from leukemia, and especially as we think of the scientific innovations in this. This kind of tells you about how diverse this team is, how large this team is. A couple of points to point out here. The yellow boxes show all the new team members they have, and some of them are in here, some of them are in the health system. One point to point out is that the classical heme is an area of huge growth and need. Partly reflects Connecticut as a state with an aging state population, that many of our sites are inundated with benign heme. It's either an opportunity or a stressor. It certainly is a lot of demand, but how do we use it for our research? I think those are some things that I know the heme group is thinking with Bob Bona and others. Also want to point out Marcus Mushin on the left. Some of you may not have met him. He is our inaugural director of CMC, or Central Molecular and Clinical Oncology. Dr. Mushin joined us last summer from City of Hope. Accomplished Harvard Hughes investigator whose goal is to bring the physician scientist. How do we train them? And he's been able to recruit 3 people in his group. So really excited about how that comes across. And then you can see how Stephanie's thinking about the network and all of the pieces. So I think this group will continue to get bigger over the next year as Dr. Weiner joins us. Next slide. Neuro-Oncology is led by Antonio Moro. They had the Shenevere Brain Tumor Fund. You saw the announcement earlier this week. They also had a U19 grant with Antonio Moro and Ranjit Bindra on launching the therapeutic network. They're continuing to do a lot of clinical trials. And then for 2022, for this coming year, their goals are to kind of optimize their inpatient services, as well as launch a PO1 in the future. And then I know that they have also the recruitment needs in this group. Next slide. All right, so therapeutic radiology or radiation oncology is a department led by Dr. Glazer, one of the top 5 programs in the country. Clearly very much definitely invested in building teams, translational science, or what we mean by taking science from the bench to the bedside. We have to acknowledge that they had the Mosaic cyber attack and how this team worked tirelessly to make sure that no patient's treatment was interrupted. And I think that's a fabulous achievement. In addition, Lynn Milson has now stepped in as our new deputy CMO for therapeutic radiology, as the idea of a cancer center and being a matrix that we need the connection. So really want to welcome Lynn formally in this role. And then for the next year, I think all of us have heard the Proton Center that will be in the Central Connecticut domain that started construction. They're working on building a spinal oncology program with neurosurgery, and Udi Mendel, Dr. Mendel just joined us. And they're also looking at a SPORE grant in DNA repair. And of course, the theme, if you've already heard, continued recruitment, back to the theme of the academic health system. Surgical services is broad. There are many, many departments. Dr. Goshen is our deputy CMO for surgical services, working across the 6 departments of surgery. Again, I'm not going to name the multiple recruitments, but they're here and in the health system. I think what has happened, and this is kind of exciting, is that we have been able to standardize some of the treatment delivery across the health system, especially in breast, and some of the more structural works. I think looking ahead, this is about part of the theme of the academic health system. How do we make sure that patients have access to surgical services in the health system. Doesn't make a lot of sense for surgeons to be going to these sites, but how do we think about that? That is an opportunity, because when we look at Smilow services, we are about 50% of the state, yet we look at surgical services across the 6th surgical department. That's not congruent. We are only about 30% of the state. So there's an opportunity to grow our surgical services. There's a lot of destination programs that are being developed with multiple teams, and you can see all those. I think we also need to think about how patients come to us not only for trials, but also novel treatment offerings. We've started the HIPEC program with Elena Ratner, and then our division, I just did a case last week for GI surgical oncology. How do we offer more advanced robotic cancer surgery? A lot of patients want to seek that out. So often those are the entries, and we need to be really tactical on how we think about that for our patients, so they look here rather than going to New York. The last division is palliative care, led by Jen Capel, and they were able to get 2 Milbank grants, one to look at providing care, standardized care for palliative care services in the cancer center, also a dashboard development. Jen also is focused on developing a system-wide palliative care program. And you can see her goals, which is to continue to build the ambulatory network for palliative care services, because there's a huge need for how we think about that for our patients. Next slide. Okay, I think you've heard enough about this over the last few weeks if you've been attending all of this. Clearly, our clinical trials increased dramatically, and then with the pandemic, we had a shutdown, and now we are enrolling, but slowly, as we have seen the labor disruption. This is what I want to stress here is what we are feeling is nationwide. If I look at all the cancer center director listservs, what we are seeing is every other center. So although it doesn't make the hard work easier, it's just to recognize that what we are facing is something that the rest of the country is facing. I think part of the pieces that we're also doing in terms of thinking about is how do we deliver care, and our DARTs, or the Centers for Cancer Care, are our vehicles for taking this tripartite mission and making it one patient at a time. And these are the cancer care teams. Now, some of them have been launched, next slide, formally into thinking about all of the domains. So now thinking about the clinical teams, the research, the quality, the clinical trials. And this is Roy Herbst and the lung team, which you can see is truly multidisciplinary. And you can see in the box all the services that go in delivering care services, and also all the sites that have to think about it, as we now have thoracic services, cancer services in both Trumbull and at Greenwich. Next slide. Similarly, Pam Kuntz launched the Center for Gastrointestinal Cancers, and this is a large, just in terms of thinking about GI cancers, and has matrix has a relationship with the digestive service line, and you can see all the leaders and all the different specialty programs. Huge complex undertaking. I want to congratulate this team in working so inclusively across the entire system. Next slide. And then the breast team just launched. As you know, Dr. Lusberg joined us recently from the Ohio State and has already been busy at work and has been building an inclusive team for breast cancer, which, as you know, is distributed throughout our care sites. Next slide. Okay, the other one, as I mentioned, is the Chenevere Fund. As you know, we got a $5 million gift from Louis and Deborah Chenevere earlier in the year, and we just announced the 3 leaders, Jennifer Moliterno as our clinical director, Antonio Moro as our clinical trials, and Ranjit Bindra as our scientific director, and thinking about destination program, and also as we launch our neurosciences tower at SRC. Next slide. Now, why, the how of what we do and what does it result in? If you look at it again, back to this network and how do we make it academic and how do we think about it, it's still relatively young as our integrated system, but we treat roughly 50% of our patients diagnosed in this state. And I think the part which I've mentioned, that patients want to be seen, especially for their day-to-day needs within closer to home. They may want to come for their complicated surgery here, but for the day-to-day, I think thinking from a patient perspective, they want that care closer to home. So the goal is to get that Smilow Center within 30 minutes. And so they have 16 locations across Connecticut and Rhode Island. Next slide. So this is a great story. I love stories because I think stories stick with us more than a bunch of factoids and dashboards. So Captain Simon serves in the public health service and was diagnosed with multiple myeloma and was treated by Jason Haldus at Waterford, and he needed a stem cell transplant, and Jason contacted Stu Sarupian, who brought him here, and he had his transplant and NP and was taken care on by the team at NP7. And then he's gone back to Waterford to get the rest of his care. I mean, that's seamless. That's the kind, we want more of this. It's not easy, but when it happens, it's like the right thing to do because, he got the majority of his care closer to home, but when he needed the complicated stuff, he came here to New Haven. Next slide. Okay, so the other part of our care centers, just some facts, which I think it's always are good to know. If you think about YNHH and Yale School of Medicine, 8% of our people across our School of Medicine and the hospital come for access to clinical trials. That's not just in cancer. But if you look in cancer, 25% of patients are on clinical trials. That's a pretty hefty number in our care sites. And then care centers deliver 40% of our cancer care. So I think you get the idea that a lot of our patients are being treated on these care centers. But how do we improve upon as the next generation as we think about the evolution of the care centers that came together by consolidation of a lot of services? I mentioned already how do we provide advanced services, whether it's therapeutic radiology, whether it's palliative care or surgical services. How do we use telehealth more strategically? And I think also what we need to do is how do we highlight what is the strength of an academic system? Why is a good pathology diagnosis, the right diagnosis and right staging important? It has an impact. If you don't stage a person right the right time, you can't go back and fix it. So I think this is something we need to do when we talk to our patients in our network to highlight what is the value of an academic health system. Yes, clearly we want to have easy access, but also what do we do that's a differentiator from, say, the others in the market is something that really needs to be something that our patients and our referring physicians and teams understand. Next slide. All right, this is all the recruitments. You've seen this over in Renee's weekly and in my monthly town halls and over the past year, but some folks to point out is Dr. Isaac Kim, who just joined us in October as the chair of urology. Dr. Kim is a physician scientist. He joined us from Rutgers, where he led the division of urology, and clinical, he's an expert in robotic prostate, so bringing that destination clinical expertise. And research he does has been developing treatments for treatment-resistant prostate cancers using PROTAC modality, which I know you've heard a lot from Joe Kim and Dan Petrolek and Roy and others. In the other recruits here to point out these continued is Dr. Krishnamurthy, who also just joined us recently as Chief of Pediatric Oncology from Emory. And he brings an expert in BMT and really excited to have him. You can see the rest, Bo Pomahawk, who has done the world's first, this nation's first face transplant, but his daytime job is cancer reconstructive services, is also here from Brigham. And I mentioned Dr. Mendel, who's here from The Ohio State and leading probably one of the world's or nation's expert in spinal oncology and recruited from neurosurgery. Okay, so switching gears to some of our research mission, I spent a lot of time on the clinical mission. Now switching gears to our research mission. As we know, we are a comprehensive cancer center, which means we're supported by a CCSG grant. And we have 300 full-time members. The grant needs a lot of work to manage it, and that work is done by Bob Garofalo, who has been leading the CCSG grant and all of the administrative workload for us since 2015. He led us through a renewal. Bob is stepping down, and Ed Kafton, who you all know, will be taken over as Associate Director for Research Affairs on January 1st. For the next year, you can see their goals to continue to improve infrastructure, operational and efficiency, and help lead our resubmission. Next slide. Okay, this kind of graph speaks to itself. I think nice steady growth of our grant funding. Important point to point out is our NCI funding or cancer specific funding has increased. We also have these research programs. I'm not going to talk about them, but I think just to say out that these 6 research programs represents our efforts for framework for engaging all of our members in high impact science. So again, it's teamwork, similar to what we said on the clinical side. And each program is often led by either by multiple leaders that bring complementary experience. And also, I think what the goal is to have synergy between them. And then each of these programs thinks about how do you mentor new investigators, and ultimately, how do we improve the number of teen science awards that are going across our cancer centers. One of the successes is this, which is the ADORA trial, which was led by Roy Herbst, and the correlative work for this done by Katie Poletti. And this is for EGFR mutated non-small cell lung cancer. And I think the Kaplan-Meier, for the folks who can see it, is you can see when you're treated with this new drug, osimertinib, which is an EGFR receptor, you can see the improvement in survival from placebo from 61% to 97%. I think that graph speaks for itself, and that this is a great trial in improving outcomes for our stage 2 and 3A patients. But also says that how, I think what this highlights is how the clinical team and the translational teams and all the teams are working together, and how what we do here then changes clinical management across the country. Next slide. Lots and lots of awards. I think we probably can't cover them all, but some few ones to think about as highlight are obviously the 2 people who got inducted into the National Academy of Science. Dr. Li-Peng Chen and Scott Miller were inducted, which is one of the highest honors in the country, along with National Academy of Medicine, Dr. Marcella Nunes-Smith. You can see Pam Kuntz got Woman Oncologist of the Year, and that led to a lot of national excitement over Pam's support on this. Next slide. Okay, so talking about our associate director, Dr. Mark Lemon is the associate director of basic science research. And as I mentioned, the Cancer Biology Institute is on the West Campus. He's been able to recruit 6 members who are really in fostering research. The goal here is to foster basic science and bring it to a translational end. And you can see Dr. Lemon's goals for the next year to help foster continued part of this translational research, and how do you work across the other associate directors in data science, and which I know is an area that Dr. Lemon is really focused on, because as we know that genomics is becoming part and parcel of our lives. Next. Okay, so the next program, Roy Herbst also runs the translational and clinical research as the Associate Cancer Center Director, and here they focus very successfully use the TTARE team science mechanism, and also are fostering this too for leading to SPOREs and PO1s. I know he would be very excited, and as am I, to mention the diversity training, both in the T32 program as well as the BMS diversity program, which is led by Naveed Hafez. For next year, of course, I think we would all agree that improving, optimizing the CTO office is critical, along with submitting at least 1 new SPORE grant. Next slide. These are all the drug approvals that have led from Yale-led studies, kind of highlighting our continued success in this arena. Next slide. And then for the CTO, I think many of you've seen this slide, but as part of improved optimizing and acknowledging our distributed system, we've announced 2 more medical directors, Stacy Stein and Neil Fishback, along with Stephanie Hillary, who runs the labs. Alyssa Gateman is our interim director for the CTO office, and Margaret Gill Shannon came on full-time as part of the Cancer Center as our new deputy director. And then I think you've all heard that Huron is helping us to say, how do we do things more in an optimized way with improving our infrastructure. Next slide. And then these centers, I think, are also important bridges that think about our DARTs, and how do we then continue to engage in this, what we call matrix, and how do we recruit new people and have them be successful. So I mentioned Cancer Biology Institute as one example. We've also mentioned CMCO, Marcus Mushin's program. He just recruited David Brom, who's going to focus on renal cancers. And you can see all the COPPER program, which is very successful. And I want to point out YCIO, which was launched as a bridge program several years ago, and as between the Cancer Center and Immunobiology. And Marcus was appointed as the full-time director recently this year. Next slide. So our AD for population, and then the SPOREs, which I think you can see the data for itself, how much funding they bring, and the leaders of these 3 SPOREs. And I think you've heard that there's goals to at least put 1 or 2 new SPOREs for the upcoming year. Next slide. So Melinda Irvin is the Associate Director for Population Science, and the goal here is how do you think about our research and focusing on our catchment area. And her goals for the next year are to see how do we take our genomic science and connect it. We are all connected by EPIC. So how do you use this data science and leverage our electronic health record with our research to be more sort of cloud, what we may call cloud analytics, is something that everybody's thinking along with. As you saw, Mark Lemon is also thinking about that. And then, of course, foster collaborations. Next. And Pat LaRusso runs the Experimental Therapeutics program. Of course, this is focused on how do we take our faculty and physician science and do investigator-initiated trials. I think things to think about is how do we also increase URM recruitment to clinical trials. And one of the ways Pat is thinking about is decentralizing clinical trials, bringing them closer. Sometimes it's hard to get here. This is where clinical trials, our geography helps us in that those trials are available to our patients. Next slide. And then if you think about our catchment area, our catchment is the state of Connecticut. And 97% of our cases come from the state of Connecticut. Now, it's important to note that Connecticut is in the second highest quintile in the country for cancer incidence, and 5% higher than the US average. In particular, Hispanic or Latino population has a 27% higher cancer rate. And that gives us, as we think about our different sites, how do we think about our research and how do we improve care? And then, of course, in New Haven, we know we have higher rates of smoking and obesity, which are also cancer risk factors. Next slide. Now, one of the ways to improve is how do you address the needs? This is one example by Andrea Silber, who has the Own It trial, which his goal is to improve minority enrollment in clinical trials. This is in breast cancer. And how do we offer that to our communities in our local community? In addition, these trials are supported not only by the CCSG or the NCI grant, but also by foundational funding, by BMS, Genentech, et cetera, in terms of trying to improve care to our communities. Next slide. Now, this is I love this story. So Marilyn Barber was having some symptoms, and she kind of went to her primary care, even was, had her levels checked, including her CA-125, all normal. She went to a health fair, and you can see some of her team from our health fairs, and really had a nagging feeling and really got some information at this health fair, came to see Alessandro Santin, actually had ovarian cancer, was treated by our team, and kind of tells you that these fairs and also have a teaching responsibility to our community. And in this case, we had an early patient's diagnosis and helped this patient. Next. Okay, and then this is part of back to our NCI grant, that community outreach and engagement is a critical part of our mission as a comprehensive cancer center. And Marcella Nunes-Smith leads our community outreach and engagement program with the goal to reduce or eliminate disparities in our catchment area. And the goal here is to use data or dashboards to then understand the burden and then use it to outreach back to the communities to then improve care. I think increasingly then, as once you understand what the problems are, also how do you ask the right questions and how do you develop your research around that is something that I know, as Marcella steps away from her White House duties, is looking to develop further. Next slide. And then last but not least, Barbara Burtness was appointed as a new interim AD for diversity, equity, and inclusion. Again, I mentioned this earlier on in our talk that this is going to be an area that's important to us, and Barbara is a huge champion of this, having done this work locally, both in SWIM and in the Dean's Committees, and nationally for ECOG. Already since starting, she's been doing a lot of training and implicit bias for trainees, for physicians, a lot of communication initiatives, as you've been seeing that on Smilow Connect. And in future, obviously, as you see, there's a climate survey going on, then of course we want to eventually get a permanent AD for this role. Next slide. And she's already launched a DEI council. It's obviously highly inclusive and diverse. And this committee, I know, will continue to look at all of our parts of our functions and to say how can we think about all these issues in equity, health equity. Next slide. And then Harry Cougar runs our education and training. She's the associate director for that. Their program is looking at how do you use metrics to improve and optimize trainee outcomes, and also how do we look at the entire pipeline of students and trainees and optimize their research experience, because this is why they come to us. Some of the other things to highlight here is the Cancer Student Interest Group that has launched, including initiative for MD PhDs. You can see the other training for APRNs for residents. Something of pride to us, 25% of our class is URM this year, and of course the fellowship will be expanding from 8 to 10 trainees, which also looking ahead. Next slide. So I want to take a moment. First of all, I want to thank, I couldn't have done this all of the months, and although I'm going to be your cancer center director for the next few months, I may not have many more opportunities with the holiday season. I want to take a moment to acknowledge the people who were silent but helping me every minute, every hour. Lori Pickens, who, as you know, is our senior VP, is phenomenal. She has always figured out ways to make, as I ran 2 departments, my life easier, and really has never made it that even if I called her on a weekend, never blinked. I think Dan DeMeo is one of the most understated and thoughtful people, and I pushed him in so much of the research and helping me in all of this, and has been an incredible help as our deputy director. Margaret, as I mentioned, just came on and was doing 2 jobs, and then I pushed her for a lot of things and she never let it on, even though she was new to her role. Obviously, there are many other folks. I can't mention them all. I do want to acknowledge Brian Smith and Tisha Johnson for all the help in the CTO office, what they did, and what Nancy and Brown and Keith Churchwell have done as we have thought about the CTO and all the things about what a contemporary clinical trials office looks like. I think I want some of the surgeons may be on, unlikely, it's noon, they're probably all in the operating room, but I also want to acknowledge my department. They did lose my attention, and that's my faculty, my chiefs who took on many, many other roles for being wonderful citizens. I do love this cancer center, but I also look forward to giving my chiefs and my faculty my time and attention. So I want to thank all of the folks who have been really incredible partners. And then I want to end on a note as we look ahead, next slide, please, of what, as we reflect and pause as Eric comes on. I look forward to working with Eric over the next few months to transition. We've already been working together on recruitments, et cetera. So I think he has a big job, but he is obviously very experienced and he has a lot of support. But I want to come back to how you all can think about what you do and how that helps us each and every day. We are one academic cancer health system. We have to think about why do we all come here, whether it's the nurses, the staff, the environmental, everyone comes with a calling. I think this was very clear when I was here during the pandemic and I saw our environmental health services and there was an empty hospital, but nursing working in units, but quiet, that everybody has a calling. Healthcare is hard, but it comes from the heart. And we all want to think about why we came to do this job. It's important to acknowledge that there's a lot of heart in doing this work. It's not just all dashboards and data and planning. I think to do this well, of course, we need to have what I call connectivity or collaboration. I gave you some examples, but there are times when it doesn't work right, and there are times when it works beautifully. It is something we are going to continue to evolve and learn to work across on how we connect, whether it's in the research arena, in the clinical arena, in quality, safety, whatever we do. But we have to do it more nimbly so we do not make it so hard for each and every one of us. And then how does it lead to a community? Some of it is internal to us on how we think about us, because all these C's lead to appropriate engagement, why we are happy at work. And not happy, haha, but why we feel satisfied with our jobs. So community building is all within us. It has to be local at the end of the day. It can't come from a Zoom meeting. It is sometimes sitting and having lunch together. It's shared in a hallway with a smile, how we greet each other. But that community has to come from all of us. Whether I see the DeLuca Awards and I saw all the nursing teams hanging out with each other, that's community. And then we also have to think increasingly as the conversation is happening on, and whether we see vaccine rollouts or others, how important health equity is in how outcomes are seen. We may do the best science, but at the end of the day, that has to be done in the where we live, and that's our patients. And they may have social determinants of health that may make the best treatments. If they can't access them, it's irrelevant. So that is also a community I want you to think about. So over the next few months, I will be here. I will be engaged, but I will also work with Eric. I look forward to welcoming him and having a smooth transition. I want to thank you all for giving me the privilege of being your leader. And with that, I hope I leave a few minutes for question and answers. So thank you so much. So we can open for questions. And it is Zoom, it's not a webinar for once, so it's okay to raise your hand and ask a question or put it in the chat.
Yeah, I'm going to lead off. Kevin Billingsley here. I first want to say thank you for your incredible service over these past many months. I can only imagine what has been involved in running the complexities of the Cancer Center and the department. And I think that although we still have challenges in front of us, I think all of us are really excited for the future, and we see the growth and we see the opportunity, and I think it's a very bright time for our organization.
Thank you, Kevin, for highlighting, because I think if you didn't sense it from my excitement, I think we have a fabulous institution and the best is yet to come, and we have great people.
Nita, this is Lori. I have to echo Kevin. And since I got here a little over 3 years ago, you were one of the first people that I came to see. And the collaboration that you have had with us in cancer from day one has been just amazing. It's just been fabulous. And there's a part of me that has to apologize a little bit for trying to get you over here to serve as our interim, because there's a part of me that feels guilty at this point as well. But you have just really stepped into this and just been an incredible partner for all of us. And probably didn't realize quite how much you would be taking on. But I just want to thank you from the bottom of my heart, because your partnership has always been so valuable, and having you here over the last, 6 to 8 months working with us like this has just, it's just been terrific. And really thank you from me, and thank you from all of us.
Thank you, Lori. So quiet group, I'm going to give a minute or so if someone wants to ask a question.
I'll ask a question.
All right, Roy, go ahead. I knew you.
First of all, I want to also thank you. It's been, and we'll continue to work a lot together. Great working with you, and especially as we've had to work through the clinical trials together, it's just been, your leadership has been just enormous. I'll ask, now that you've seen the Cancer Center, and as you go back to be chief of surgery, which it sounds like is a pretty big job, what have you learned? How can we build better multimodality clinics? So one of the things that we really want, I think, to increase our care, our reputation, is to really be seeing patients with tumor boards in a multimodality way across the system. And I was wondering what you've gleaned from this experience that could help us as we move forward.
Yeah, no, really good question. I think first of all, thank you for all the hard work you've done. I think I put surgeon hours with you every day, so thank you for bearing with me. I've had a chance to visit some of the care centers. Unfortunately, I didn't have a chance to visit each and every one of them. But I think what struck me is how connected the patients were for their local community, and how incredible the service and the teamwork was. I think at least my department wasn't as distributed until we came, and then some of the folks like Nina Horowitz and others were incredible champions of taking breast care. But I think there's opportunity for us in even sites like Waterford and Torrington. I think the part that we have to figure out is how do we make it not so difficult, because it's not efficient for us to put everybody in the clinic at the same time. So I think some of the pieces will be, and I kind of put the telehealth piece, to me, that is an opportunity around thinking for the specialty cares. For some of the care like breast cancer, we may want to think about, should breast cancer, all of the services be available at every site? And again, this is work I know Liz Star Herbert is thinking about with the rest of the teams and with Jeremy and Ann and others. But this is the pieces that we have to think about on the part. Now, there are some challenges of thinking about this. Sometimes our teams are multiple employment models. It doesn't mean it's good or bad. We just have to think tactically around, if imaging is not Yale Medicine, but someone else, how do we make sure we're still working as a team and thinking on these systems? The last piece I'm going to tell, and this is an opinion, so please, but I do think that there's still a lot of education that's needed on the importance of multidisciplinary management, and to our patients, who are ultimately, it's their health, and not to the physicians, but to our patients and our primary care doctors, especially in Southern Connecticut, where there's a lot of people whose first thought is to go to New York. And in my mind, that should never happen. If you are a patient in Connecticut and you have Yale Cancer Center in your background, they should know all of us. But I can tell you there are many times they don't know all of us. And they call me and I answer these phones and I'm like, well, here's the world's best expert in XYZ, but they're not aware. So that education is upon all of us. Every interaction is an educational opportunity. And that is what we have to do to educate our communities on what we bring in language that they can understand. And it's easy to explain this. So again, that's what I mean by a distributed health system, to explain what is, whether it's therapeutic, importance of giving IMRT, radiation, or whether it's proton, or whether it's complicated clinical trials or complicated surgery. But there's a huge opportunity, and obviously we will be working with your teams to sort of make that happen. All right, it's 12:58. I want to give people 2 minutes back. I hope everyone had lunch, but thank you all. You're an amazing group. We are very large, we are strong, and I want you to acknowledge yourself, and I want to thank each and every one of you for making this, and for coming through the pandemic and continuing our growth. Thank you, everybody. Have a great rest of the day.